I may start, otherwise I might start sharing the screen if you want.
Yes, please.
Do you see me?
Yes, everything looks perfect. I see you perfectly, and I hear you. And
Okay.
we are 17 now and increasing.
Good.
So yeah, definitely let's wait a couple of minutes more.
Okay.
So we also have the special issue on brain and spine, which should be changed.
Yes,
regarding
that's
its name.
that was great news. I was absolutely excited. Yeah, I think they are understanding finally that neurosurgery has to be considered as brain, spine, and nerves.
Yes.
It took us
guess...
quite a while, but eventually we will get there. I'm pretty positive.
Yeah. Yes. Congrats. Because you did a great job on that issue. And besides, I think there are some copyright issues or things like that, legal issues regarding the name of a journal. Maybe that's the reason why.
Yeah, this is also something that we have to take in consideration. But anyway, I mean, it's a start, and that's the important thing.
Yeah, definitely. You want me to start with introducing you?
I think we better start. Yes.
Okay. Well, hello, good morning, good afternoon, good evening for everyone. This is a very special webinar on anatomy of WFNS Rhoton's webinars. This is number 7, but also our guest speaker is a wonderful start in the peripheral nerve world. I'm very glad to introduce to all of you, Debora Garozzo. Debora not only is a very, very good friend for many years, but also she now chairs the World Federation of Neurosurgical Societies Committee on Peripheral Nerve Surgery. So she's very active. She's career is awesome because she started in Italy, where she was born, in Sicily, and then she went to Rovigo in the north of Italy, but she wouldn't stay in only one place. So after that, she started to travel all around the world, especially in China, where she learned very interesting and new techniques. Also, she came back to Italy, and after a long and very productive career, she's now working in Dubai. So, Debora, welcome. Thank you very, very much for being our speaker today. It's a great pleasure.
So thank you so much. It's actually my utmost pleasure to be the speaker for this webinar today. And I also would like to say a big thank you to you for taking care of this collaboration with the WFNS Neuroanatomy Committee. I think it's extremely important because whenever we want to do surgery, anatomy is actually the platform that we have to build our knowledge on. So today, the topic is actually a little bit challenging, I would say, because we are going to talk about the anatomy of the lumbosacral plexus. The lumbosacral plexus is not one of the most common topics normally. So we are going to try to briefly give an overview on the anatomy and also the surgical approach. But I will also try to specifically focus on the correlations between anatomy and clinical presentation and pathology. So everybody knows that the lumbosacral plexus is the network that is responsible of providing sensory and motor innervation to the lower extremity. It's located in the abdomen, deeply located in the pelvis, and anatomists usually prefer to divide it into 2 components. We talk about the lumbar plexus for the upper part and the sacral plexus for the lower part. Some anatomists also prefer to identify a 3rd component, which is the pudendal plexus, but I prefer to follow the division into lumbar and sacral plexus. So, We know that both the brachial and the lumbosacral plexus are formed by spinal nerves that after they exit from the foramina will split into two branches. The posterior branches, the posterior rami are responsible of the innervation of the paraspinal muscles, and the anterior divisions form the plexus, the brachial or the lumbosacral plexus, like we are talking about in this case. So here we have a small video which is going to show you the foramina. That means the exits of the spinal nerves for the lumbosacral plexus. So the spinal nerves, which are responsible for the formation of the lumbosacral plexus, are normally the roots from L1 to L3. However, as we have seen already for the brachial plexus, there might be variations, and these variations are those related to the so-called prefix and postfix plexus. So the prefix plexus is a lumbosacral plexus that receives a contribution also from the 12th thoracic spine, the last thoracic spine, and this contribution is given via the subcostal nerve. And the contribution from S3 is missing in these cases. On the contrary, when we talk about a postfix plexus, it may happen that there is no contribution from L1, certainly no contribution from T12, but on the contrary, we see that there is a contribution quite significant from the sacral roots, including S3 and S4. Now, anatomical variations are encountered in all the nervous system. We have also anatomical variations in the brachial counterpart, but I have to emphasize that anatomical variations for the lumbosacral plexus are particularly frequent. And I'm trying to mention some of the most common forms when I'm going to talk about the detailed anatomy of each of the collateral and terminal branches of the sacral plexus. So let's start talking about the upper portion of the lumbosacral plexus, which is the lumbar plexus. It's formed by the anterior divisions of the spinal nerves from L1 to L4. And as we said before, may also quite often receive a contribution from the last thoracic nerve. The lumbar plexus is retroperitoneal. It's adjacent to the lumbar spine and located on the posterior wall of the lesser pelvis. And it's typically embedded in the psoas muscle. We are going to see that this is a very important detail because the psoas muscle, and in particular, the lateral edge of the psoas muscle, is actually going to be our landmark when we do surgery. So the lumbar plexus has collateral terminal branches, and we are briefly trying to talk about all of them. We're starting to see this slide, which in my opinion is actually a very good overview, because not only gives us the possibility to focus on the branching of each spinal nerve and identify the origin of the terminal branches of the lumbar plexus, but also shows us the extension of the lumbar plexus. And as you can see, the branches can reach all the way down to the ankle, thanks to the saphenous nerve, which branches off from the femoral nerve. So let's focus 1 second on the origin of the branches of the lumbar plexus. So L1, which is the upper roots of the lumbosacral plexus, splits into two branches, which are the iliohypogastric and the ilioinguinal nerve. But it also gives a contribution that, coming together with a contribution from L2, forms the genitofemoral nerve. Then we have a contribution from L2 and L3, the posterior rami, that is responsible of the formation of the lateral femoral cutaneous nerve, a nerve that is very well known by the neurosurgeons. And then we finally have the two main branches, which are the femoral nerve and the obturator nerve. Now, I'd like to start talking about the first branches, which are the iliohypogastric nerve, the ilioinguinal nerve, the genitofemoral nerve, and the lateral femoral cutaneous nerve. And the first thing is that, again, as I mentioned, we may found a lot of anatomical variations in comparison with the pattern that I mentioned before. And you can see it reported here at the level of this, watching these pictures from Cadaver Lab. So let's start to talk about the iliohypogastric nerve. I mentioned before that L1 splits into two nerves, which are the iliohypogastric and the ilioinguinal. Now, this splitting actually does not happen 50% and 50%, but there is a different way. It can be that we have an higher contingent of fibers for the iliohypogastric nerve or the way around. And actually, sometimes in up to 20% of cases, the iliohypogastric nerve may be absent, and all the fibers from L1 are actually carried on the other nerves, and in particular the ilioinguinal nerve and the contribution from the genitofemoral nerve. Now, anyway, once the iliohypogastric nerve branches off from L1, it travels retroperitoneally behind the kidneys, and we can locate it emerging from the upper lateral border of the psoas major. Then the nerve runs in front of the quadratus lumborum muscle above the iliac crest, and then eventually will pierce the abdominal wall and splits into its terminal branches. So the terminal branches are cutaneous branches and motor branches. The motor branches supply the internal oblique muscles, and also the cutaneous branches supply the sensory innervation for the superior gluteal region and also part of the suprapubic region. The other branch coming from the L1 root is the ilioinguinal nerve. We can say that this nerve kind of follows a similar course than the one that we mentioned for the iliohypogastric nerve. We can also see that it comes out of the lateral border of the psoas muscle and follows more or less the same course of the iliohypogastric, running in front of the quadratus lumborum muscle and above the iliac crest. And then eventually it also pierces the abdominal wall, and we are going to talk about that better. And it is responsible of providing innervation to the transverse abdominis and the internal oblique muscles, but it also a nerve which contains sensory fibers, and these sensory fibers are going to distribute to the external genitalia in both the men and women. And here we have a description of the area encountered, innervated by the ilioinguinal nerve in the two genders. Then the genitofemoral nerve. It's a mixed branch as well that comes from the upper roots. And it also forms from a contribution from L1 and L2. And it's interesting to see that it follows a different course of the other two, because once it is formed within the bulk of the psoas major muscle, it actually pierces the muscle itself, emerging on its anterior surface, running along the anterior surface of the psoas major, and eventually splitting into the branches, which are the genital branch and the lumboinguinal nerve, which then will continue downwards. The genitofemoral nerve is also involved in the sensory innervation of the perineal area, and here we see the differences again between the two genders. So I just wanted to sum up something which is quite important, which is, how we can trace the exit of these nerves. Let's not forget that the first two nerves that we mentioned, the iliohypogastric and the ilioinguinal nerve, usually are located along the upper lateral border of the psoas muscle, whereas the genitofemoral nerve runs on the psoas muscle after having pierced it. Now, this nerve is a nerve that most of the neurosurgeons, and in particular peripheral nerve surgeons, know quite very well, the lateral femoral cutaneous nerve. This is a nerve that is formed by a contribution from L2 and L3, and it also can be located at the level of the psoas major muscle, and then it travels downward and reaches the inguinal ligament, goes under the inguinal ligament, and then at the more or less passing over the sartorius muscle, splits into its terminal branches. And its terminal branches are responsible of the sensory innervation of the lateral and anterior surface of the thigh. So as I mentioned before, this is a nerve that we all know quite well, because it may happen that it gets entrapped. An entrapment of the lateral femoral cutaneous nerve is responsible of the onset of symptoms, pain and paresthesias in its sensory distribution, and this is related to the pathology that we call meralgia paresthetica. Now, something that is, again, I think it's important to highlight are the correlations between the course of the nerves that we have talked about until now, and also the surgical implications. So as we have seen, all these nerves are responsible of the innervation of the innervation of the inguinal region. And this is also one of the reasons why, if general surgeons are not particularly aware of the course and especially of the exit points of these nerves, they can involuntarily injure them, especially during surgery for inguinal hernia repair. So we really have to consider the importance of the entry points of the nerves in the abdominal walls, considering, as I mentioned before, that we always have some variability. So the iliohypogastric nerve usually is above the iliac crest and lateral from the anterior superior iliac spine. The ilioinguinal nerve entry point is the one that presents the greatest variability, because this nerve can pierce the abdominal wall either above or below the iliac crest and lateral from the anterior superior iliac spine. And its terminal branches, the genital branch, goes around the internal inguinal ring, and the femoral branch may be either cranial or caudal. And concerning the lateral femoral cutaneous nerve, and this is quite important when we do the surgery for the decompression of the iliac crest as well, or also as I mentioned before, for inguinal hernia repair, the entry point may be either medial or lateral to the anterior superior iliac spine. Now we are going to talk about the main terminal branches of the lumbar plexus, which are the femoral and obturator nerve. So these are nerves that branches from L2, L3, and 4. So the anterior divisions of the spinal nerves from L2, L3, and 4 splits again into rami, a posterior and an anterior rami. So all the dorsal rami come together to form the femoral nerve, and all the anterior rami come together to form the obturator nerve. The femoral nerve is the most important and thickest nerve of the lumbar plexus. And again, we have an anatomical variation of its origin, because what may happen is that in some individuals, there might be also an accessory iliacus muscle that implies that there is a split femoral nerve. Now, according to some authors, this anatomical variation may present a correlation with symptoms that could be related to a femoral neuropathy. So patients with femoral neuropathy related to this kind of anatomical variation could present sensory disturbances or sensory loss along the anterior and medial surface of the thigh, or even develop a motor deficit involving the quadricep muscle. I have to be honest with you, and I have to say that this is something that I have found only described, but I had not the possibility to observe clinical cases like that myself in my practice. I don't know about Mariano if he has experience of something like that. The femoral nerve, have you seen something like that?
No,
So
no.
Okay, so you also agree with me. I haven't seen anything like that. Okay.
Absolutely no.
Okay, the femoral nerve, then once we have seen it emerging from the lateral board or the lateral edge of the psoas muscle, then travels downwards, trying to reach the thigh. And during this course, branches off for the iliac muscle, the psoas muscles, but also gives a branch which is for the hip joint. So we have also an articular branch. Then it goes under the inguinal ligament, and once it reaches the thigh, it will split into its terminal branches. We have, again, motor and sensory branches. We have the lateral and medial musculocutaneous nerve. Then we have the branch that goes for the quadriceps, and therefore it's a motor branch. And then we have the saphenous nerve. The saphenous nerve is just sensory fibers, and we have seen it at the beginning. It's a nerve that really travels a long way because it goes all the way from the thigh down to the ankle, providing the sensory innervation of the medial calf. And it's a nerve that unfortunately can sometimes damage when there is, for instance, a procedure of stripping of varicose veins. I think all of us peripheral nerve surgeons have seen complications of varicose veins procedures with injuries of the saphenous nerve, right? So here we are going to see a video that shows the course of the femoral nerve in the pelvis. It's a little bit more, it helps to get a three-dimensional visualization of the course of the nerve. So now we are going to talk about the obturator nerve. As I mentioned before, the obturator nerve, like the femoral nerves, also comes from L2, L3, L4, but these are the anterior rami of the anterior divisions of the spinal nerves. Now, again, as we mentioned also for the other nerves, we have some anatomical variations. We have mentioned that it comes from L2, L3, L4, but this is the pattern in approximately 80% of cases. But there is a quite significant percentage, approximately 18% of cases, where the contribution from L2 is missing and the obturator nerve is formed only by L3 and L4. Moreover, it may happen there is also a bifurcation of the nerve, which is mostly seen in the obturator canal. And also we can see that there might be cases, approximately 1/3 of individuals where there might be an accessory obturator nerve. And this is something which we are going to see. It's particularly important when we talk about the surgical approach. Here we have another video showing you the course of the obturator nerve. So we have briefly given an overview of the lumbar plexus, and now we start talking about the sacral plexus, which is particularly important also from our point of view because it gives origin to the most important nerve, the thickest nerve, there is the sciatic nerve. Now, there is a structure which is particularly important that we need to talk about, and this is the lumbosacral trunk. Now, the lumbosacral trunk is extremely peculiar because it provides communication between the lumbar and the sacral portions of the plexus. Basically, it's formed from L4, so there is a contribution from L4, and then L5, all the fibers from L5 goes into the lumbosacral trunk. Once the contribution from L4 and the fibers from L5 come together, and the lumbosacral trunk is formed as a single entity, it passes over the ala of the sacrum adjacent to the sacroiliac joint. We are going to see also the importance now that we talk about the formation of the sciatic nerve. So the sacral plexus as a main terminal branch, which is related to the formation of the sciatic nerve, but we are going to talk also about two other nerves, which are the posterior cutaneous nerve of the thigh and then the pudendal nerve. Here you see the extension of the sciatic nerve, which takes origin from L4 and then all the way down to S3. And it's particularly important that we focus on the formation of the nerve itself. So within the sciatic nerve, we can actually distinguish quite clearly two components. One component is the lateral component that will eventually give origin to the common peroneal nerve. And it is formed by the dorsal divisions of the ventral rami from L2, L3, and L4. Whereas the anterior divisions coming from the L2, L3, and L4 ventral rami will come together to form the medial component of the sciatic nerve that once the sciatic nerve splits at the level of the distal thigh will become the tibial nerve. So this information is particularly important when you have sciatic nerve injuries, and it's something that we always should keep in mind. I'm not going to talk in detail about the tibial nerve and the common peroneal nerve. I just want to remind that the tibial nerve is usually less vulnerable than the common peroneal nerve. And for instance, when we see patients that sustain a proximal injury of the sciatic nerve, like for instance, it happens as a iatrogenic injury in hip replacement or hip surgery. We usually see that the tibial nerve, even if initially affected, may then eventually recover, whereas the lateral component, which is the one that eventually will give origin to the peroneal nerve, is mostly affected. Here, I want to show you the formation of the sciatic nerve. So, something that has been mentioned in the video is the fact that there is a relation between the sciatic nerve and the piriformis muscle. And this relation is incredibly important because, again, we have a lot of anatomical variations, as you can see. So what may happen is that the two components, the lateral and the medial component of the sciatic nerve, sometimes may not just run together surrounded by just one sheath, but sometimes they may actually present separate courses. And if this is the case, it may happen that, for instance, one of the components goes above the piriformis muscle and the other comes at the level of its lower border, or one can actually pierce the piriformis muscle, or one can be above and the other one can pierce. So you see them here and they are differently represented. Now, what we have to mention about that, the different anatomical relations related to the formation of the sciatic nerve and its exit point in respect to the piriformis muscle seem to be extremely frequent. It has been calculated that approximately 38% of the population may present these anatomical variations. Now, it has been considered that these anatomical variations may actually be responsible of entrapping the intrapelvic portions of the sacral nerve and sacral nerve roots, and that consequent to this compression, to this entrapment, there might be the onset of symptoms. Now, one of the most frequent would be the onset of pain and paresthesias in the distribution of the sciatic nerve, which would be related to the piriformis syndrome. Now, I want to emphasize that the existence of the piriformis syndrome itself is something that is extremely controversial in the peripheral nerve surgery community. We have surgeons that are advocates of its existence, and there are others like myself, and I know also Mariano, who are quite reluctant to consider that a big nerve like the sciatic nerve may be compressed by the piriformis muscle. Personally, all those cases of piriformis syndrome that I have seen were basically secondary to trauma and, for instance, formation of intramuscle hematomas in the piriformis muscle. But otherwise, the onset of symptoms as an idiopathic form is really particularly uncommon. And therefore, the statement of these authors that I quoted here is not something that I agree with. Mariano, I think you are also on my same page for that, right?
Absolutely. I didn't want to interrupt you, but you know how I think about this.
Well, maybe we can talk about that more when we are doing the discussion as well. So, yes. Other branches from the sacral plexus that we have to take in considerations are the gluteal nerves. So we have the superior gluteal nerve and the inferior gluteal nerve. Now, the superior gluteal nerve is formed by the dorsal divisions of the L4, L5, and S1 nerve root. And it has a peculiar course because it goes above the piriformis muscle, and this means that it may be quite vulnerable to damage, apparently especially in cases of intramuscular injection. This is a problem that you see a lot in Southeast Asia when the intramuscular injections are not done by medical professionals, and unfortunately they have a lot of injuries in this situation. The superior gluteal nerve is responsible of the innervation of the gluteus medius, the gluteus minimus, and the tensor fasciae latae muscles. And it is extremely important from a functional point of view because the innervation of these muscles is essential in order to keep the pelvis at the same level when we walk. So if there is an injury of the superior gluteal nerve, it will trigger weakness on these muscles, and the patient won't be able to maintain the pelvis at the same level when he's walking, consequently having a drop contralaterally, which is going to be the so-called positive Trendelenburg sign. So here you can see the normal gait and the abnormal with the positive Trendelenburg sign. The inferior gluteal nerve is responsible of the innervation of the gluteus maximum, and it's less vulnerable because it's more protected because it goes under the piriformis muscle. Now, just a few words about the posterior cutaneous nerve of the thigh, which I just wanted to highlight because of its importance when we examine a patient. Because to detect the presence of a sensory deficit in the distribution of this nerve that covers the whole posterior surface of the thigh is something which represents a very important element that can give us the possibility to understand whether the injury is related to the proximal it's a proximal injury of the sacral plexus, or it's a sciatic injury and therefore a more distal injury. And finally, just a very few words about the pudendal nerve, which comes from S2, S3, and S4. And as we know, is a nerve that contains both motor and sensory nerves, as well as sympathetic autonomic fibers. The pudendal nerve is extremely important, not only because it provides a sensory function for the external genitalia in both genders, but also along the perineal floor, but also because it's responsible of the motor supply for the male and female external urethral sphincter and the external anal sphincter. So a damage at the level of the pudendal nerve actually causes a significant inconvenient, a very significant deficit for these patients. Here you can see the distribution of the pudendal nerve in the two genders. And here particularly I want to focus on the distribution on the females, because unfortunately this is a nerve that can be very easily damaged during child delivery for the females. Now, these two slides, from my point of view, are probably two of the most important slides of this talk, in my opinion, because I try to provide here an overview of the nerve, mentioning the roots, the plexus, and then the terminal branches of the lumbosacral plexus. I tried also to give for each nerve also which is the muscle innervation and the distribution in the sensory area. So I think it can be actually a quite useful sum up of what we have seen until now. So in this first slide, you see the roots and the plexus, and here you can see the femoral obturator sciatic muscle innervation, the loss of the reflex, and also the distribution for the sensory innervation. And just to review also the sensory innervation, this is a slide that shows you the distribution for each dermatome. Okay, at this stage, I think we have briefly reviewed the quite complex anatomy of the lumbosacral plexus, and I do hope that I tried to be clear enough. And we are going to talk about surgery. So which are the reasons that we have to approach surgically the lumbosacral plexus? Well, we may have the main three chapters of peripheral nerve surgery for the lumbosacral plexus here as well. We may have the presence of tumors, we may have the occurrence of injuries, and then entrapments. To be honest with you, I do not have encountered so many entrapments in my life. And what I am going to focus mostly is going to be talking about surgical approach for tumors and for lumbosacral plexus injuries. So I want to start stating that lumbosacral plexus tumors are quite infrequently found in the general population, differently from what happens in the patients affected by neurofibrosis. All of us who deal with this kind of patients know that the detection of intrapelvic masses is quite frequent, and it's very important to screen the patients for hidden pelvic masses, because we know that they are very often asymptomatic, but unfortunately, in 1/3 of cases, they may undergo malignant transformation. Then we have to talk about lumbosacral plexus injuries. We may consider obstetrical and post-traumatic injuries. Obstetrical lumbosacral plexus injuries are extremely rare, we do not really have much reported in the literature. Personally, I have seen just one case, which is the child in the picture here. Lumbosacral plexus injuries, and this of course is also something to consider for the obstetrical pulses, are less vulnerable to damage because of the strong osseous connections between the pelvis and the lower extremity. Anyway, it is calculated that approximately in 1% of pelvic traumas, there might be a lumbosacral plexus injury, which I actually think that it might be an incidence likely to be underestimated. It's important to remember that these are usually injuries that we see in massive pelvic traumas, and this is the reason why associated injuries are particularly frequent. Over 90% of patients present bone injuries. Then there might be also injuries of the internal organs, and in approximately 10% of cases, there might be also vascular injuries. We divide 4 types of injury patterns. The most common clinical presentation is that of the affecting the lumbosacral trunk injury. And I have to say that this is a presentation that sometimes can be quite difficult to be identified by somebody who's not particularly experienced. And it's especially in this case that you have to keep in consideration the differential signs that I showed you in the slides before. After the lumbosacral trunk injury, the most statistically frequent is the sacral plexus injury. Total lumbosacral plexus injuries are fortunately definitely less common, and the least frequent type is the lumbar plexus injury, which unfortunately very often is damaged in the course of surgery. It's also interesting to note that there might be quite a significant percentage of patients that may present a bilateral injury, approximately 6%. Now, as I mentioned before, the strong osseous connection between the pelvis and the lower extremity make the lumbosacral plexus less vulnerable in terms of injuries. And this is extremely important, especially when we consider the avulsions, which are significantly lower than for the brachial counterpart. For the brachial plexus injuries, we know that 70% of patients with a brachial plexus injury may harbor avulsions. For the lumbosacral plexus, the incidence of avulsions is approximately 22-25%. And usually, typically, avulsions occur at the level of L5 and S1. It's unlikely that you are going to see avulsions of the upper roots or of the lumbosacral plexus. So the low incidence of avulsion injuries, and also the fact that there are so many anatomical variations of the lumbosacral plexus, explain why we have actually a quite high percentage of spontaneous recovery. Fortunately, 70% of cases may present a spontaneous recovery. But we have to consider that usually the early signs of spontaneous recovery can be detected quite significantly later than with other nerve injuries, and the time to recover is extremely long. It may range from 8 to 36 months, which means 3 years. The average I have seen is approximately 18 months. Now, of course, these patients, if they do not recover, the 30% of patients that does not seem to recover may have to go for surgery. And we follow the same criteria that we have for the brachial plexus. If there are avulsions, we have to go for surgery as soon as possible. If we have not evidence of avulsive injuries, but we think that it's a post-ganglionic injury, at the beginning we have a wait and follow-up approach, and we normally follow the patient for approximately 6-8 months, so longer than for the brachial plexus. And then if there is no spontaneous recovery detected clinically or also on electrodiagnostic tests, that we may have to give indication for surgery. Talking about that, we also want to focus on the way we study these patients. And differently from other injuries where we normally rely on electrodiagnostic studies and imaging with MRI, I have to say that for these lesions, it's also essential to include an angiogram in the diagnostic workup, because as I mentioned before, quite frequently we have vascular injuries, or also because for the surgical approach, it's better to know the anatomy of the vessels. So how do we surgically approach these lesions? For the upper lumbar plexus, which means from injuries or for tumors that affect L2 and L3, we have to use a lateral retroperitoneal approach. For the lower lumbar plexus and for the lumbar sacral and for the sacral plexus, then we will use a midline transperitoneal approach. And we also have to consider that there might be cases where we have to do an intradural exploration. Now, what clearly is evident is that except the intradural exploration, which can be done via a posterior spinal approach neurosurgeons are familiar with, the lateral and the midline retroperitoneal approach are not surgical approaches neurosurgeons are familiar with. So that means that we have to set up a multidisciplinary collaboration with general or urological surgeons. Now, I'm going to give you a few examples of surgery for tumors and then for injuries. So let's start talking about the lumbosacral plexus tumors. The first case I'm going to show you is the case of a quite bulky neurofibroma that was detected in a 25-year-old girl affected by neurofibromatosis. And we did the approach with the general surgeon, as I mentioned before. And what is important to consider if you have a case like that is that it may happen it may happen that you are going to damage the ureter, which also runs along the lateral edge of the psoas muscle. So a good thing to do before you actually start the surgery is that you want to protect the ureter, and you can encannulate it with a double J. And on the right side of the slide, you can see that here we have identified the ureter, so we were able to protect it and not damage during the surgery. And the slide shows our landmark, which was the lateral edge of the psoas muscle here, which, as you can see, has been displaced. And here you have the surface of the tumor that was eventually removed en bloc. So this was a case for an upper lesion. If we have to access a lesion at the level of the sacral plexus, things become definitely much more complicated. We have too many structures, and especially if we have cases of traumas, there is a lot of scarring and fibrosis in the area that may really make this approach quite complicated with high rate of post-op complications. So this is the reason why, whenever possible, I try to avoid a direct approach via the abdomen, and try to find some tricks, to say so. And I'm going to show you a couple of these procedures. So this is the case of a lady that had a past medical history of ovarian cancer, and she was submitted to radiotherapy. And unfortunately, she developed, as you can see here, a pear-shaped tumor affecting the intrapelvic course of the sciatic nerve that eventually turned out to be an MPNST. So what we noted is that the inferior pole of the tumor would actually reach the sciatic notch. So we considered that we might try to approach this tumor from posteriorly. So what we did was that we detected the insertion of the gluteus maximus medially. So we exposed the edge of the sacrum. And then we considered that we may actually enlarge the sciatic notch. So we would have a bigger window to be able to remove the tumor. So what we did is that we actually removed a triangular fragment of the sacrum, and this actually gave us the possibility to make the sciatic notch much larger than originally would have been, with a good exposure of the tumor, and we were actually able to remove the tumor with this approach, avoiding to go via the abdomen. This is another case with a quite peculiar approach. This was a neurofibroma, again, in a patient with neurofibromatosis, and it was an intrapelvic tumor located between the rectum and the coccyx. So what we consider is that we might easily access it if we would remove the coccyx, and this is what actually we did. So this is the incision, and I think it's interesting that you can see the popping up of the cutaneous neurofibromas. We expose the tip of the coccyx, and then that was removed, and again we had the possibility to access the tumor and completely excise it and block. Now we can talk about surgical approach for lumbosacral injuries. And before we start getting into the details of the surgeries, there are a few considerations that we have to make. Now, right now, we have no possibility to recover the foot function. But we have to say that this is actually not a very big deal, because when we walk, the foot function is not relevant to our ability of walking, because what we need in order to walk is actually pelvis stability, and we already talked about the importance of the innervation of the gluteus muscles to keep the level of the pelvis stable when we walk. And also, the other thing that we need is that we need to bring forward the lower extremity. So I'm going to show you a video of this patient that unfortunately sustained a femoral injury. So this patient presented a tumor of the intrapelvic femoral nerve that was operated by a general surgeon. The general surgeon just removed the tumor, cutting the femoral nerve. And as you can see, the patient developed quite a significant deficit. Although he was then operated by a peripheral nerve surgeon in London, there was not a good recovery of the function of the muscles, and the patient is now obliged to walk with this very heavy device. I wanted to show you both of the videos exactly because this clearly gives you an idea of how affected the life of this patient has been by a surgery which has not been correctly performed. So you have seen the way he struggles to walk because he's not able to bring the leg forward, and this device, although quite bulky, is what enables him to have an autonomous walk. On the other side, this is a patient with a gunshot injury of the sacral plexus, and because the iliac psoas and quadriceps muscles work, as you can see, despite of the fact that there is a very severe deficit with denervation and foot drop, he can anyway certainly walk better than the other patient. So these two examples were just shown to confirm once again that in order to walk, what we need is the stability of the pelvis and the possibility to flex and extend the thigh. So this is why when we have a lumbosacral plexus injury, our surgical priorities are to restore the function of the femoral nerve if we have a lumbar plexus injury, to restore the function of the gluteal nerves in cases of sacral plexus injuries, and we have to combine both in those patients that unfortunately sustained a complete palsy of the lumbosacral plexus. Now, the surgical approach are quite complicated, and we are briefly going to review both the intra-abdominal and the extra-abdominal approaches. there is something that I have to mention before we start talking about that. The lumbosacral plexus injuries, as I said before, they are rare. Fortunately, most of these patients recover spontaneously. So the series related to surgery of the lumbosacral plexus injuries are actually very small, not particularly statistical significant, and the cases which have been operated were just more or less anecdotal. So we are still very much in an experimental stage, I would say. Because of the difficulties that I mentioned before, especially when we have to approach the sacral plexus, this is why recently we prefer to approach these lesions with nerve transfers, and we are going to briefly review a few of them. Now, injuries affecting the femoral nerve, like the case that I showed you before of the patient that sustained the iatrogenic injury after the removal of the tumor. We say that we can go with lateral retroperitoneal approach. We have to expose the lateral border of the psoas muscle, because this is our anatomical landmark to identify the femoral nerve. Now, if we cannot directly repair the nerve because we cannot retrieve both stumps or they are not available, what we can do is that we can use the nerve transfers for the renervation of the femoral nerve. The literature usually quotes that we can use the lower intercostal nerves, the 10th and the 11th. But for instance, in a case that we did, we have also tried to use the L1 anterior division, which means that we sacrifice the iliohypogastric and ilioinguinal nerves. There was not much else that we could do, and we took this choice. And here you can see the femoral nerve, and then this was a case of a lumbosacral plexus injury. And here you can see the two nerves, the two donor nerves with the recipient nerve. Another possibility for nerve transfers would be to sacrifice the obturator nerve and use it as a donor nerve for the femoral nerve. However, we have to consider that this would imply the functional impairment of the adductors, unless it's one of those cases, which, as I mentioned before, it's 1/3, 30% of cases, where you have an accessory obturator nerve, which is only responsible of the innervation of the pectineus muscle, and therefore we can easily sacrifice it with no significant comorbidity afterwards. But the femoral nerve can also be extra abdominally renervated. And this means that we can use donor fascicles from the sciatic nerve if it's working, or again, use the obturator nerve. And it's a quite complicated procedure, because we have to also consider if we are going to damage the, sorry, I went back to the slide. Especially, the selection of the donor fascicles from the sciatic nerve is actually something which is not particularly easy. Now, things become even more complicated for the renervation of the gluteal nerves. So again, we considered that we could use the 10th and the 11th intercostal nerves to get to the gluteal nerves, but this unfortunately requires a quite long interposition graft, and that might jeopardize the chances for a favorable outcome. So it has been considered that another option, which might be responsible of providing a more favorable outcome, may be taking donor fascicles from the femoral nerve. Now, this becomes a quite challenging and time-consuming procedure, because we have first to expose the extrapelvic femoral nerve. We have to identify the donor fascicles, paying attention not to damage the femoral nerve as well. We have to prepare the recipient nerves, which means that we have to expose also the subgluteal course of the sciatic nerve and also the gluteal recipients. And then we have to harvest the sural nerve so that we can interpose the graft between the donor fascicles from the femoral nerve and the gluteal nerves. And this interpositional graft has to be done underneath the tensor fascia lata. So it's also quite long, although probably not as long as from the intercostal nerves. And, you know, as I said, again, these are all anatomical cases. For total pulses, we have very complicated strategies. One of the things that we might do is an intradural exploration, hoping to retrieve if there is a damage, not a avulsions, but just a rupture of the roots, to do an intraoperative root repair. But I have to say that this is a very unlikely statistically chance. So what we can do is that we may actually try to use donor fascicles, motor fascicles that can be harvested from the contralateral side. And then again, we have to connect them with a sural nerve. And then the sural nerve has to go up through the dura. It has to be tunneled, subcutaneously tunneled, and eventually reach the gluteal nerves. So again, quite long graft and quite time-consuming and complicated procedure. For the subgluteal cords of the sciatic nerve and then the gluteal nerves, usually we need a wide exposure, so we have to go with the so-called Andrews approach, which implies that we have to detach and immediately displace the gluteus maximus and open it as a book, like you see in the slide here. However, sometimes it may happen that the patient are referred to you with significant delay. And in these cases, we might consider the possibility for muscle transfers. Now, there is something that we have to say. Some of the muscle transfers to regain pelvic stability, which are mentioned here, are actually quite rarely performed. And I can tell you that also the way they function, also the patient is not immediately able to understand what is the mechanism to use this muscle transfer. So the ones that we use a lot, and this is something that usually happens for the sequelae of patients with lumbosacral trunk or sacral plexus injuries, is the tibialis transfer, which is a procedure that is extremely common, also because it's used for distal injuries, like for instance in common coronal nerve injuries. I would say that's all. I do hope that I did not put too much on your plate, and that more or less I tried to highlight which were, at least from my opinion, the most important things talking about the lumbosacral plexus injuries. And of course, I'm available for questions or comments, remarks.
Thank you very much, dear Debora. What a difficult topic. Thank you for coping with this. Thank you. So we have limited time because this webinar should last 1 hour, and it was really wonderful, and we have a lot of information. Anyhow, we have some questions, and I will ask Debora. Please write your questions in the chat if possible. Otherwise, open your mics. And the first one would be by Ahmed Nashad. Many thanks. Excellent. Can you please describe your steps in a nerve transfer? How you do it?
We are talking about a specific nerve transfer or a general nerve transfer, because I mean then this is going to be not another webinar, another 5 webinars about it, depending on what we want to talk about.
Yes.
I mean, what we can say is that the main, let's talk about the general principles that we all know. So basically, when we do a nerve transfer, we consider that we want to renervate a nerve whose function we consider a priority for us. and we have to select the donor nerve due to its proximity, and also to the fact that this stock should this donor should not have an important function like the one that we want to restore. This is basically what I can say. But if you want to know the steps by step of the nerve transfers, I mean, it's quite complicated.
No, maybe this is a good moment to briefly review, maybe if you want, one of the most important and most recent nerve transfer that has been employed in this type of injuries, which is the obturator to the femoral nerve transfer. What is your vision on that nerve transfer,
so
which has been compared
again,
with the overland transfer?
As I have to say, it's really difficult to eventually give an overview of how this nerve transfer work, because the cases are very anecdotal. I don't even remember how many cases I have done of nerve transfer for the brachial plexus, but I have to tell you that probably my overall experience in lumbosacral plexus injuries doesn't go more than 10 cases, a dozen cases. It's difficult. So what I can tell you is that the obturator, also one of the things is that we actually lost some of the patients on follow-up. So few cases and also lost on follow-up. What I can tell you is that the cases where we used the obturator nerve, as I said, were cases when we could find there was an accessory obturator nerve. And this is something because especially when we at the first patient and we mentioned that we were going to use the obturator nerve, the patient gave us a very good insight, because he said, well, but because of this injury, I actually sit on a wheelchair. And one of the things which are very important for me is that I have to move the leg to abduct the thigh. And if I don't have the obturator nerve working and my abductor muscles are paralyzed, this means that I am actually going to have even a more significant deficit, whereas you cannot offer me any guarantee that the nerve, that the renervation is going to be successful. So this is why I specifically highlighted that the transfer between the obturator and the femoral nerve, in my opinion, should be done only when you have the evidence of an accessory nerve, which is, as I said, 30% of cases. There is something I also wanted to say. In the past, I think we have read in the literature, those were papers published by the group of Susan McKinnon, that when you do a nerve graft, you probably would have better results if you use a motor donor instead of the sural nerve that, as we all know, is just a sensory nerve. And this is something that I would like to say. Let's consider that the obturator nerve as a function, which might be quite important. And personally, I don't think we should sacrifice the obturator nerve because we think that we may have better results than usual using the traditionally sural nerve. I don't know what you think, Mariana. I mean, my idea is that we always have to add to the function of the patient. And when we choose a donor nerve, we have to consider that the donor nerve really is not adding comorbidity to the patient.
Yes, absolutely agree. Let's move forward. Álvaro Villabona from UK. Thanks, Dr. Garozzo. Very positive comments, by the way, dear Debora, for your talk.
Thank you. Thank you.
You mentioned that patients with NF2 can experience malignant transformation. Do you recommend screening imaging of the lumbosacral plexus in NF2 patients?
Absolutely. Actually, I would like to say thank you to Álvaro Villabona for this question, which is essential. So we have high chances in patients with neurofibromatosis that they have asymptomatic tumors that may undergo transformation. So for NF1, we have to say that the correlation between hidden pelvic masses and malignant transformation, it has been calculated in about 1/3 of cases. So for me, all patients should be submitted to MRI for total body. That gives us the possibility to screen the patient from head to toes, literally, and to detect the hidden masses. And then for that, we have to focus with the study, with the MRI, particularly on that region. For the other types of neurofibromatosis, like for NF2 and, for instance, for schwannomatosis, for NF2, I do certainly recommend again the total MRI, the MRI of total body.
Yeah.
For the schwannomatosis, we do not have a clear evidence that the schwannomas may undergo malignant transformation. There have been some anecdotal cases, but we have not been able to establish a clear to establish that as clearly as for the patients with NF1, at least in my experience. I don't know, Mariano, if you agree.
No, yes, completely agree. And what about chemotherapy? Ahmed is also asking in NF2. Do you have any experience with that, or
so you're talking about NF2 or NF1?
Yeah.
Because what I can
the question is for NF2, actually.
Well, NF2 chemotherapy is something that
I guess
I
he
honestly,
I think
it's
refers
probably
to
a
the new
typo.
drugs. I guess he refers to the new drugs that deal with vestibular schwannomas and all that.
Well, again, these are all quite anecdotal experiences. Most of the trials are actually experimental. They have not recruited a significant number of patients, and there is something that we should always consider. Patients that present neurofibromatosis, and when we try to prevent the further growth of tumors are usually children or teenagers, and we always have to evaluate how much the prevention may be useful. So, for instance, for plexiform neurofibromas, there has been quite a wide spectrum of drugs which have been used in trials to try to see if we could control the growth of the neurofibromas, and some of them have actually been discontinued because they trigger quite significant side effects in these children, and there was no that very clear statistical evidence that they would actually block or delay the growth of the neurofibromas. So for me, we don't really have much evidence that these protocols are useful. And personally, I don't have any direct experience with that. Also, these are usually something which is administered by the oncologist or by the pediatric oncologist following these children.
Great. As I said, many positive remarks from Ibrahim, from Carlos Alberto Rodriguez, Elena Tabela, Hushang Saveri, Mami Rabari Javona, and so on. Debora, a couple of questions more. We might have some time for a short answer. This is a difficult one. How to diagnose femoral neuropathy due to accessory iliacus?
Okay. As I said, I have just found that mention in the literature, and I do not have a personal experience with that. But I would suggest that if you have a patient with symptoms that can be suggestive of this kind of problem, the first thing that certainly is that we have to image the patient, and I think an MRI is essential. And then I think that if you have a skilled neurophysiologist, they would be the one that they can tell you whether the compression of the femoral nerve is proximal or more distal. So I think you cannot just have an idea based on the clinical presentation. It can be quite tricky, but I think you have to rely a lot on the workup.
Yeah. Okay. Also in MRI, of course. This is
exactly,
the only way we can diagnose.
And probably MRI more than electrodiagnostic tests, because I could believe that you have the onset of a femoral neuropathy, especially if there is something which is contributing. But as I said, just the anatomical variation, I don't think it's enough to trigger the neuropathy.
Yeah. I have 3 more questions. Good morning, by Olga Alarcon. In case of approach to OLIF spine surgery, L3, L4, or L4, L5, sometimes there is a lesion to brachial to lumbosacral plexus by retraction. How to avoid this injury?
Okay, this is another very appreciated question, because there is something that we should consider. Intraoperative electrophysiological monitoring should always be available. If you want to perform this kind of surgical approach, you have to consider that you have to protect yourself, and it would be preferable that you have an intraoperative neurophysiological monitoring. And by the way, I think that should be also recommended to orthopedic surgeons when they do hip surgery, because it can really prevent a lot of problems. But in the unlikely case that an injury occurs, because as the participant herself asked, this is usually something which is related mostly to using retractors and therefore giving a stretching injury. Usually, you just need to give indication for physiotherapy, and then after a while, we should observe a spontaneous recovery.
Perfect. Carlos Alberto Rodriguez, we know him very well, good friend.
I have an idea. I know this guy, yeah.
A bit distal anatomical question. Injuries to the inguinal complex of nerves is relatively common after inguinal hernia surgery. What is your preferred strategy, either proximal disconnection or decompression at the site of primary surgery?
I think I usually go for a decompression at the site of the primary surgery. And again, this is a surgery done very few times, and I have always done the revision surgery together with a general surgeon. And to be honest with you, one of the things we saw is that most of the times there was something related to the way they positioned the mesh for the inguinal nerve repair. And removing the mesh was just enough to, if not completely sort out the symptoms, at least to give a very good subsidence of symptoms.
Perfect. And the last question would be by Ahmed. What's your experience with postoperative foot drop after lumbar spine surgery?
Well, again, these are very general questions, because then, a postoperative foot drop, it might be because you have maybe used a root retractor and you pulled too much, or because you just did an injury. So it's if it's a postoperative foot drop that was not for sure evident before the lumbar spine surgery, I think that Dr. Ahmed probably refers to discectomy, I would assume. Then usually, again, what we do is that we give indication for physiotherapy. We follow up the patient, and then we consider that the injury is irreversible if we do not see a consistent improvement within 6-8 months after the injury. And usually after 1 year, you see more or less what the patient was able to recover. What is important to say is that when you have a post-operative foot drop in cases of lumbar spine surgery, it's actually a little bit of a mess because there is not much to do. Because the muscle transfers that I mentioned, which are extremely successful, for instance, in the cases of lumbosacral plexus injury for the lumbosacral trunk and sacral plexus injury, cannot be applied in these cases, because let's not forget that for a muscle transfer to be successful, it has to score at least M4 preoperatively. Now, when there is a radicular damage, the tibialis posterior, its damage itself, it might be weak as well. And we have to consider that every time we make a muscle transfer, there will be a downgrade. So if the muscle scores M4 preoperatively, after the muscle transfer, it will score M3. So if you have a muscle donor which is less than M4, which is going to be an M3 preoperatively, and you do the transfer, it won't work because it's not going to be strong enough to give the movement. So a postoperative foot drop after lumbar spine surgery is a situation where we can only hope that it's going to be sorted out spontaneously, because personally, I don't think right now we have very much to offer to the patient because muscle transfers cannot be done. The nerve transfers for the lower limb, like for instance, using fascicles from the branches for the sartorius muscle, sorry, for the
obturator. Obturator?
Yeah. No, I'm talking about the distal ones. The one, for instance, you have a foot drop, and then we are going to use
the soleus to the anterior tibial.
the soleus. Sorry, the soleus. I'm for the selecting branches from the soleus. They don't really work that well as well. I mean, we don't. We had a webinar some time ago with Leandro Preto Flores, who is actually the one that suggested this kind of nerve transfer, and he's probably the one with the highest experience. And he also had to recognize that differently from the upper limb, the nerve transfer for the lower limbs are not actually that effective. So we do have a problem.
Yes. Okay. Well, last question would be: there are any proven drugs to restore nerve conduction? And probably the best drug to restore nerve conduction is surgery. What do you think about this?
Yes, exactly. No, we do not have any evidence of a medical treatment for nerve injuries. We definitely have to consider only surgery.
Well, that's it. There's a lot of interest. Many people connected till now. We have 1 hour and a half of webinar. So I really appreciate everyone's connecting here, having questions, and for your attention. And very especially, Debora, thank you very much for this wonderful talk. We really appreciate it. Thank you.
Thank you so much, Mariano. It was a pleasure. And well, I do hope to see you in one of the next webinars again. Okay?
Hopefully,
Thank you,
yes.
everybody. Bye-bye.
Thanks.